All right. Good morning. Thank you all for joining us. My name is Star Jones, and I'm the Cancer and Chronic Disease Unit Manager at the Wyoming Department of Health. And this webinar today is being hosted in partnership with American Cancer Society, the Wyoming Cancer Coalition, and the Wyoming Cancer Program. The meeting is being recorded, and the slides will be made available on our website and will be sent out to all meeting registrants. Please feel free to introduce yourself in the chat box with your name and organization. And if you could rename yourself on your screen, there's a couple glitches on Zoom that shows that I'm in here a few times. So if you want to go ahead and rename yourself, that would be wonderful. And then introduce yourself in the chat box. So as many of you are on the call today know that cancer is the second leading cause of death in Wyoming, and Wyoming is ranked 40th in the nation for cervical cancer screenings. So fortunately, there are more ways than ever to prevent cancer and find them early, offering improved health outcomes. And the Wyoming Cancer Coalition published our latest cancer plan in March of this year, and cervical cancer remains one of the highest priorities identified. So one resource to help with cervical cancer screenings is the Wyoming Cancer Program, which is housed within the Wyoming Department of Health. And that program provides reimbursement for Wyoming providers for breast, cervical, and colorectal cancer screenings to Wyoming residents who are uninsured and underinsured at or below 250% of the federal poverty level. And that program covers screenings such as mammograms, Pap tests, colonoscopies, and at-home stool testing options such as FIT kits and Cologuard. So for more information about those screening programs, I will put our website in the chat box here shortly. And so now it's my pleasure to introduce you to today's speakers. So today we have Jane Smith and Dr. Saslow joining us. Jane will be the presenter, and then Dr. Saslow will give some information here and there. So Jane is the program manager for cervical cancer screening at the American Cancer Society based in Salt Lake City, Utah. And prior to transitioning to her current position, Jane worked on HPV vaccination efforts in rural Montana West states with American Cancer Society, and has previously worked on the opioid prescription guidelines at the CDC Injury Center. She is passionate about health promotion and health equity so that all people can live life to the fullest. And then just a little about Dr. Saslow. She's the managing director of HPV and gynecological cancers at American Cancer Society. Since 1997, she has served as the ACS subject matter expert for HPV-related cancers, including cervical cancer. And she provides strategic direction and evidence-based guidance to the organization on the implementation of HPV-related cancers activities, and is responsible for developing and updating ACS guidelines for cervical cancer screening and for HPV vaccination. And Dr. Saslow has also served as the vice chair of the National HPV Vaccination Roundtable since its inception in 2014. So please help me welcome Dr. Saslow and Jane Smith.
Great, thank you so much. I'm going to go ahead and start sharing my screen. And if I could get a thumbs up that you all can see that. All right. Okay, great. Thank you so much. And thank you so much for having us here today to talk about cervical cancer screening in recognition of Cervical Cancer Awareness Month. I hope this information is useful to you, not only in the month of January, but in months going forward as you work in your cervical cancer prevention and screening space. So I am going to kick off today's presentation with a bit of interaction from the audience. And so there will be a couple of polls throughout our presentation today. So I would greatly appreciate if y'all were able to contribute. We're going to use a tool called Slido. And so you can either pull out your phone and scan the QR code in the upper left-hand corner, or you can go to slido.com and there is a box where you can enter the meeting password, which is the CCAM 2022. And once you're there, you can enter in your result or your answer about what role do you play in preventing cervical cancer, so I can get a feel for who's in the room and joining us today. Great, providing education, local resources, educating the community. Education and screening assistance, I'm noticing a theme here. We've got lots of education and support for evidence-based interventions, education, vaccination. This is great. Promoting early screening and detection. I also get my screenings. That's good to hear. I hope that this information is not only useful for you as a professional, but also as a person. Vaccination. Great. Thank you so much. Awesome. Okay, well, you all are getting the hang of Slido. It's pretty straightforward. And with that, and in the interest of time, I'm getting a good feel for who we have in the room. Education, awareness, vaccination, screening. This is great. So I'm going to go ahead and move on to the next slide. There will be future opportunities for you to also participate in our polls. So thanks so much for being willing to engage. Okay. So without further ado, we're going to jump straight into cervical cancer data. I'm going to highlight a bit of the national data, and then I have a slide too about Wyoming. But this slide is, we're not going to go into depth into this slide, but this is highlighting the cervical cancer burden in the US. For 2022, there's going to be an estimated about 14,000 cervical cancer cases with about 4,200 cervical cancer deaths in the United States. And so this is just helping to frame a little bit of why we're all here, and we can help prevent these cases and deaths too going forward. And then you'll see on this slide here that these are the trends in where cervical cancer incidence rates have been going over the past couple of decades. So you'll see it's from starting about 1975 up to 2018, which is our most recent data. And you'll see this general trending downward, which is a really good sign. And this is because of the implementation of new screening technologies and better knowledge of disease mechanism. But we still have a ways to go to get this rate to continue to decrease. And so that's hopefully why you all are here today and why we do our work that we do. And then just highlighting, I know that STAR also kicked off with this data point too, but Wyoming ranks 40th in the United States for cervical cancer screening. And you'll see here that Wyoming, 83% of women aged 21 to 65 received a Pap or an HPV test to screen for cervical cancer. And the national average is about 85%. I just want to draw attention though that these are pre-COVID rates. This is 2018 data. And we know that we saw a significant decrease in the screening rates during the pandemic and continue to see this as we're trying to get them back on track. So it's really critical that we get these screening rates back to pre-pandemic levels and continue to increase the screening rate both in Wyoming and nationally. So I just wanted to draw attention to that. And now we're going to transition into our screening guideline that we produce here at ACS. All right, so in July of 2020, ACS released our cervical cancer screening guideline, which is an update from our 2012 guideline. And on the following slides, I'll talk a bit more about the specifics that were included. And as well, and maybe this can go out too in the chat or following, we'll send out a link to that guideline as well. All right, so the age to start screening is 25. I know that this was, my sister is 21 years old actually, and she was talking to me about this, and I was like, she's like, oh, I gotta do this thing where I have to call the OBGYN and set it up. I was like, actually, you know, you could pause and wait a little bit. And so she was like, really? And so we had a good conversation about this. But there are lots of reasons that we have the age to start being 25. And we know that cervical cancer rates are really low among those in the early 20s. And so if you see the last bar on the screen is that 20 to 24 years old, and that's the smallest bar that we see there on the screen. And so the incidence rate of cervical cancer in this age group is very low. And you'll see here, this is kind of a mirror of that same graph, but this is showing the distribution of cervical cancer deaths by that age. And you'll see in the 20 to 24-year-old age group that also has the smallest bar on the screen. So you have more rationale to start at age 25. Okay, Now my next Slido poll is here. And so there are 3 different tests that we currently use to screen for cervical cancer. There's the Pap test, there's co-testing, which is a combination of the Pap test plus the HPV test, and then there's the HPV test on its own, often called primary HPV. And so if you want to go ahead and pull out your phones, you can use your Slido app on the phone, or you can use it on the website, whatever is easiest for you. That would be great. I'm seeing co-testing is the front runner, the early front runner here. Great, I'm seeing more and more people contribute, and co-testing is staying at the front. I'll give it just a couple more seconds for more people to jump in and select their multiple choice answer. Oh, I'm seeing a couple primary HPV popping up. Great. All right. Any last minute responders we have here? Okay, awesome. Well, I think that this actually tells a really interesting story and also translates well into what we're going to talk about here in the next coming slides. So it seems like a majority of those who are either recommending screening or are being screened or doing the screening are using the co-test, which is the Pap test plus HPV. And then their primary HPV is getting some love in the Slido. So thanks for participating. We're going to close this poll down and move over here. So there are several tests, as we just saw, that can be used for screening. And ACS recommends using the primary HPV test for screening for cervical cancer. And so just as some background information, the HPV test and the Pap test are actually collected the same way. And so for a Pap test, a healthcare professional will use a tool and gently scrape or brush the cervix to collect cells to determine if there are any precancerous changes in those cells. On the other hand, the HPV test, collected the same way, looks for the presence of cancer-causing types of HPV. And so the most important thing overall is to get screened regularly, no matter what the test, but we have a preference to the primary HPV test because it does a better job at detecting and identifying cases where cervical cancer may develop. And I'm not going to dive into this slide too much here, but this is just to show you kind of the breakdown of the 3 different tests. So cytology, otherwise known as the Pap test, and what the definition of that is. And then there's the primary HPV test and the co-test. One thing to note, there are 2 FDA approved primary HPV tests, the COBAS HPV and the OnClarity HPV. And just so you know, in co-testing, which is the Pap and plus the HPV test, the HPV test that's included as part of the co-test cannot be used in primary HPV testing. So I won't dive in too much more to that, but this will be included in follow-up information for you all. Okay, so digging in a little bit deeper to the next layer of the difference between the HPV versus the Pap test. We know that Pap tests are an inferior test when compared to HPV-based screening. We also know that Pap tests are minimally effective in women and people with a cervix who have been vaccinated. And so when you're comparing the 2 of them, HPV comes out on top. And then we also, I know a lot of people, I think it was 92% of people selected the co-testing option as in our poll. And so we also know that co-testing offers minimal benefit when compared to primary HPV screening. And then a majority of the benefit that comes from the co-test is derived from the primary HPV test. So this is just to highlight some of the reasons why ACS went ahead and said primary HPV is the preferred screening strategy. Okay. So I would love to use your Slidos. Once again, you can use the QR code, you can enter it in your browser. So I know we have a lot of people here who are invested in education, people who get screened themselves. So feel free to use this as either as the professional in the room, but also the person who's also being screened. Okay, so I'm seeing a couple of different responses here. Great. Okay, so it's looking like every 3 years is taking the cake here in our Slido poll, followed by every 5 years. More than 5 years is getting, oops, sorry about that. Oh, hold on. There we go. Zoom has been a little challenging for me today. Sorry about that. Thank you all. So it looks like every 3 years is coming out as the forerunner, and then every 5 years. So we are going to jump ahead, and let me jump into the next slide here. Okay, so the ACS guideline says to test every 5 years with using a primary HPV test. If you are using co-testing, every 5 years is also the acceptable interval, and then cytology is every 3 years. We know that it is safe to test every 5 years. And we also know that overscreening, or doing it at a shorter interval, so every year or twice a year or every 2 years or every 3 years, sometimes overscreening, and then as a result of overscreening, overtreatment can cause harms to the person being screened. And some of these harms include adverse pregnancy outcomes, such as preterm birth or low birth weight of the baby, unnecessary anxiety and stress of the person being screened, and also discomfort. And we also know that at most points in everyone's here in this room and nationally, almost everyone will get HPV at some point in their life. And so by overscreening, sometimes we're picking up things that may not necessarily be important to catch. So every 5 years is a very safe interval. There's been a lot of research and rigorous review of this. And so 5 years for the primary HPV test is the recommended screening interval. Okay, and when to stop screening? Age 65. But it's important to note here that screening can stop at age 65 as long as the patient meets the criteria to exit screening. And some of those criteria are no history of cervical cancer or advanced cervical cancer neoplasia, so some of those pre-cancers in the past 25 years, or if the person has had a total hysterectomy, which includes removal of the cervix, or if the person over the past 10 years has had documented consecutive normal screening results before age 65. So if one of those conditions if those conditions are met, welcome, you can exit screening at age 65. And it's really important that we talk about this because cervical cancer screening is less accurate and more challenging in older women. And we also know that 25% of all cervical cancer deaths occur among women diagnosed after age 65. And actually, we just got wind, there's a recent study that used national claims data. And what they found was only 22% of women who were in that 64 to 66 age range met the criteria to exit screening. So only 22% of women could confidently move on and exit screening, there's clearly a lot of work to be done around this age group too. And so a significant fraction of our cervical cancer deaths, if we remember from that initial graph that had all those lines and those bars of the incidence and the death rates, a huge fraction of cervical cancer deaths that occur each year in the US could be averted by adherence to the screening recommendations, especially in the decade leading up to age 65. All right, and who does not need to be screened for cervical cancer? And so just so we all are on the same page here, these guidelines are for women and people with a cervix who are at average risk. And so women and people with a cervix who have had their cervix removed, for example, as part of a total hysterectomy, or they were not born with a cervix, do not need to be screened for cervical cancer. And this is really just a recap of the past couple of slides that we've gone into. And just to give you the high level overview, screening is not recommended for those under age 25. Cervical cancer and cervical cancer deaths are very rare before age 25. Ages 25 to 65, we recommend getting screened with a primary HPV test every 5 years. If a primary HPV test is not available, and we're going to dive into this part too, because we know that the primary HPV test is not accessible to everyone across the United States. Getting screened with a co-test every 5 years, so that's the HPV plus Pap test, or a Pap test every 3 years is considered acceptable currently. Getting screened, no matter what the test, regularly is most important. And then those over age 65 should stop screening as long as they've met the eligibility criteria to exit screening. These guidelines apply to those who have a cervix. So this includes women who have not had their cervix surgically removed, transgender men who retain their cervix, and non-binary people with a cervix. These guidelines also apply to people who have received the HPV vaccine. And then, as we've mentioned, people who have had a total hysterectomy, which includes the removal of the cervix, should stop screening unless it was done for treatment for cervical cancer or cervical precancer. And so, of course, talk to your doctor too if you have questions about cervical cancer screening, but this is just that high-level overview of what we talked about all in one place. Okay, and as we were talking on that last slide, just wanted to draw attention as we're looking forward to the future. This ACS guideline that was released in 2020 is called transitional, meaning this is the first time ACS has ever done this in a guideline. And so we're calling this transitional because we have included co-testing and cytology testing, which is the Pap test, as acceptable options for cervical cancer screening, because access to the preferred screening option, which is primary HPV testing, may be limited in some settings. And so as the US is making this transition to primary HPV testing, the use of co-testing and cytology alone for cervical cancer screening will be eliminated from future guidelines. And so we are preparing for the future. We know we can't make a cold turkey transition. And so we know that there's a lot of behind the scenes work that has to be done in order to improve access to primary HPV screening. And so as we're looking forward, this is something to keep in mind. So this is another slide to reiterate that this guideline is transitional. In the future, Pap tests will be phased out, co-testing will be phased out of future guidelines, and primary HPV will be the preferred screening strategy. Okay, so an important distinction too, while we talk about this idea of planning for the future, is this future of self-sampling. You may have heard it called self-collection as well, but self-sampling is going to play a really prominent role pending FDA approval. So it is not currently FDA approved, but is on the horizon. And this will play a prominent role in cervical cancer screening once we have the regulatory, so the FDA approval, and clinical prerequisites and logistics all in place. And so this is, I think, a really important planning for the future item, specifically in Wyoming, because we think that this will have a really strong impact in underserved rural communities. It can address a lot of barriers to traditional HPV screening methods, such as increased travel time, lack of available providers in rural areas, as well as a lack of time. So this is a really exciting thing that's on the horizon. It is not FDA approved yet, but it's something that we imagine will likely follow a model similar to at-home stool tests for colorectal cancer screening. And so while these logistics and this regulatory approval is still being worked out, it's something that we're thinking about too, because self-sampling can only be done for HPV. It cannot be used to collect a Pap or a cytology sample. And so as we're thinking about planning and transitioning, if self-sampling is on the horizon, which in other countries this is, this is currently being used, they already have the HPV in place, and then they have self-sampling in place as well. So this is really kind of, they're piggybacking off of each other with the importance of preparing for a future in cervical cancer screening, where the HPV test is our main form and preferred form of screening. That being said, when an HPV test comes back positive, there will still be opportunities where Pap may come in, where we need to do further testing to better understand the diagnosis of the person who is being seen. Okay, Planning for the future, again, here, we also know that we have a vaccine that prevents cervical cancer and 5 other types of cancers. And so encouraging HPV vaccination is cancer prevention and will have downstream effects on cervical cancer screening, such as permitting less frequent screening or permitting screening starting at a later age. And this is also being done in other countries, where some countries don't start screening for cervical cancer until age 30. Okay. So we're going to pause as we're about halfway through our presentation here. Some of these take-home messages that you can take away from what we've had so far. Focusing efforts on unscreened women is huge. We know that unscreened women are disproportionately affected by cervical cancer, and that we see most of our cervical cancer cases and deaths in women and people with a cervix who are unscreened or never screened. So frequent screening, so these are your people who want to get screened every year or so, can sometimes lead to more harms than actual benefits. HPV screening has many advantages, as we've talked about, and so this is why it's called our preferred test. HPV screening is at the 5-year interval is extremely safe. We know that we get better detection and have to do less procedures as a result, so it's kind of a win-win. And then also, just as a highlight, these guidelines are based on a very rigorous review process with experts from all across the country, and this achieved broad consensus too. So if you take something away from the first half of this presentation, you can take some of these bullet points home with you. And now this is a question that we commonly get asked, and just wanted to highlight some information that relates to these. And there will be a slide too, a couple later on, that might help clear this up too. So there are 3 guideline producing groups for cervical cancer screening, and that's the ACS, American College of Obstetrics and Gynecology, which is ACOG, and the US Preventative Services Task Force, so USPSTF. And so we often get asked why the ACS guideline, the one that was released in 2020, is different than the others currently. And what we say is it's truly a matter of timing the updates. So actually, the USPSTF recently closed out their public comment period for their draft research plan for their update of the cervical cancer screening guideline. And we're really optimistic that they will align with the ACS guideline, given the science and what was included in their draft research plan. And then to get at the second question that's listed on this screen here, what impact will these differences have on insurance coverage? Primary HPV screening is currently a recommended strategy by the US Preventative Services Task Force, so it is covered by insurance. Health plans follow the USPSTF under the Affordable Care Act, so it is primary HPV is currently covered. There's just a lot of other considerations that need to be made in order to transition to primary HPV screening, and that leads us perfectly into our cervical cancer screening initiative. So the American Cancer Society, we put out this guideline in 2020, and we sat down, and it's, how do we get from where we currently are in screening to where we are going with primary HPV screening? We're in this transitional state. And so using ACS and our role as conveners, we gathered about 100 people from all across the country, and we've taken issues that we know are necessary to think through when it comes to transitioning to primary HPV screening, which we'll show you on the next slide here. And our goal as a group and as an initiative is to create a roadmap with tools and recommendations from where we currently are to how we transition to screening with the primary HPV test in the United States, and who's responsible for helping to make these changes so that we can transition and provide better cervical cancer screening to the people who live in this country. And so we have 6 work groups as a part of this initiative, and we also have a steering committee. So we have the Moving from Cytology Alone work group. And so we know that there are more challenges and significant challenges in areas that screen exclusively with cytology or Pap that have to go and jump from Pap to primary HPV. So they're working on some of the specific challenges that come along there. And also we know that a lot of those areas that are screening with just the Pap alone are sometimes in under-resourced areas too. So they're working on primary HPV and what it looks like in those environments. We have a patient perceptions group, so dealing with patient education, but also what is the perceptions around primary HPV screening? We have a laboratory infrastructure group. It's really important to think through all the logistics, not only from the time a person walks into an office and gets a sample taken, but also what happens on the back end and how is that processed. Provider needs, provider education. So this is a huge topic in terms of there's so many different elements to educate providers on around this new transitional to primary HPV screening. IT, AHR needs, similar to this laboratory infrastructure, there's more than what goes on in a clinical interaction too that can help to impact primary HPV screening and this transition process. And then we also have a work group dedicated to insurance coverage and payers. There are going to be a lot of cross-cutting topics between these groups, so there will often be overlap where the groups will connect and work together, but also we have a steering committee who is helping to oversee some of these cross-cutting issues and provide expertise and opportunities to collaborate across groups. Okay, all of those groups that we've mentioned are already meeting and they're really energized and they're really excited about this project. And we're already in conversations about what are these barriers that we need to really be breaking down and addressing, and what do potential deliverables, products such as tools and implementation plans look like. And so we're in this phase 2 of convening these groups and starting to have these conversations. And then over the next year and a half, 2 years, 3 years or so, we'll work on recommending these strategies, creating that roadmap and those tools to be used. And then the end result is adoption of primary HPV screening. And so not to spend a lot of time here, but this is just to show kind of how all of these groups fit together to provide this enhanced cervical cancer screening and management landscape. So we talked about those are the 3 groups that produce screening guidelines. So ACS, US Preventative Services Task Force, and ACOG, they manage that screening portion. Then we see CCSI as the implementation arm of this landscape. So how do we get from these are the screening recommendations to actually being adopted? Then there's management. So say an HPV test comes back positive. What do we do after that? How do we manage positive results or positive cases? And so there's a group that's dedicated to releasing those management guidelines. And then lastly, you'll see enduring guidelines. This is a group that's taking new technologies that are on the horizon and really doing the data assessment and the risk assessment around them so that we have really good science to talk about the different technologies that are coming up on the horizon. So this is just a little overview of how we see all these different pieces working together so that we can prevent cervical cancer. And so we really see this initiative as an opportunity to really push these recommendations forward and push them into the implementation space, and really helping this process of becoming more aligned across screening guidelines, allowing groups to take responsibility to support implementation efforts, and hopefully seeing widespread impact in cervical cancer prevention. So then we'll shift gears a little bit here. So that's our CCSI, otherwise known as our Cervical Cancer Screening Initiative. And we really want to now talk like even bigger and broader, this idea of elimination and HPV vaccination. So we can eliminate cervical cancer in our lifetime, which is pretty incredible. And we think by 2060, if the 2 blue bullet points are met, we can achieve this goal. And so elimination is really defined as a reduction of cases to 0 or very close to 0 in a defined geographic area. And so this is a very real possibility if routine screening and treatment of cervical precancers continues, and then sustained 80% HPV vaccination coverage for preteen boys and girls. And so I feel very inspired when I see this, that the efforts that you all are doing too around education and promoting awareness are contributing to this elimination effort. I won't spend too much time here on our HPV vaccination guidelines, but ACS does have HPV vaccination guidelines, and really just the high level overview of them is girls and boys should get 2 doses of HPV vaccine at ages 9 to 12. Children and young adults up to age 26 who have not received the HPV vaccine should get vaccinated. And that ACS does not recommend HPV vaccination for persons older than 26 years old. And so we're really emphasizing this 9 to 12 age group because we know that higher on-time vaccination rates equals an increased number of cancers prevented. So in order for the vaccine to really do its job and be as effective as possible, on-time vaccination, so vaccination between 9 and 12, is really crucial. And then catch-up vaccination for adults older than age 26 is not recommended for several reasons, but primarily there's a low effectiveness of the vaccine in preventing cancer. And so there's a lot of HPV vaccination resources out there, specifically through ACS, but that is our recommendations and stance there. And I just want to highlight here that 88% of protection against invasive cervical cancer when vaccinated before age 17. That's a pretty darn effective vaccine out there. And I want to highlight some data that's been coming out. There's been some really exciting research that's been produced recently. And you'll see here in the upper table, you can look at the age at which these people were vaccinated, and then their effectiveness against CIN 3+. So this is some more advanced cervical precancer. So these are the things that we really want to catch early and treat so that they don't turn into cervical cancer. That's that CIN 3+. You'll see if the age of vaccination was 12 to 13, so the younger group, there was an 86% effectiveness against preventing cervical cancer. And so in the lower box, you'll see that among the population that they studied, 538 cancers were in the unvaccinated group. And there were only 19 cases in the vaccinated group, and 2 cases when the vaccination age was between 10 and 16. So this on-time vaccination is really crucial, as well as it plays a major role in preventing cervical cancer and working towards this goal of cervical cancer elimination. Okay, shifting gears now to talk about health equity. So it's really essential to discuss health equity when we talk about cervical cancer. Like many health issues, there are significant health disparities when it comes to cervical cancer. And some of you, a lot of you, this may be common knowledge, but just wanting to put this out here that health equity is really that everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. And it's not the same as equality. So the top image is equality. Each of the people there has the same bike, as opposed to the bottom where they have a bike that's more appropriate for them. And so equality is providing everyone the same tools, whereas equity is providing tools and resources based on the needs that allow everyone the opportunity to be as healthy as possible. And this concept applies when we talk about cervical cancer. And you'll see here, this is just a breakdown of the incidence rates and death rates, and in this case by race and ethnicity in the US. And you'll see that racial and ethnic minorities are more disproportionately burdened by cervical cancer. And it's really important to keep this and other groups in mind as we design strategies to decrease the burden of cervical cancer in the US and globally. And so when we think about these different populations, we're really focusing on who is not getting access to screening. It's this really focus on those who are underscreened or unscreened. And I think someone puts in the Slido their involvement with access or potentially this program, but this might not be news to you, but there is the National Breast and Cervical Cancer Early Detection Program. And this program helps low-income and uninsured and underinsured women gain access to timely breast and cervical cancer screening, diagnostic and treatment services. And also they have a patient navigation service too. So just as a highlight here that this is one of many options when we're thinking about ways to increase screening, that this program is a huge asset to us. Okay, screening during the pandemic. So if you'll remember it very early on, and Star mentioned this too, we saw that slide where it's 83% of Wyoming people had been screened for cervical cancer screening, or had been screened for cervical cancer. But that was 2018 data, and we know that the pandemic has had impacts across all cancer screening and vaccination. So we're 2 years into this pandemic, so this is probably all repetitive information, or we've talked about the pandemic at large, but we know the high level that cancer screening remains a public health priority. We also know that screening disparities are already evident and without a deliberate focus are likely and continue to increase as a result of COVID-19 pandemic. And so engaging patients and getting back on track with screening is really crucial. And so the implementation of process and policy changes to get people back to screening are huge. All right, audience engagement time. If I could have everyone pull out their Slido here. If you've been involved in these efforts to get people back on track in the pandemic with their cervical cancer screening, what have you been doing? What are the strategies that you've been employing? And on the next slide, we'll talk through some specifics of different strategies that we can recommend, but I would love to know in practice, what does this look like in Wyoming? All right, I'm not seeing any, oh, there we go. Oh, okay. This webinar is social media messaging, getting out about getting screening, movie theater advertisements, education. I know that people have had to be really creative with how they've approached COVID, but also still prioritizing cancer screening, trying to partner with providers. Good. Let's see if we could see just a couple more. And then we can jump into our next slide. Education, social media. The social media is really booming as an avenue too for change, which is cool. Okay, awesome. Well, thank you so much for, oh, here we go. Offer vaccines, education, social media. Awesome. Well, thank you so much for engaging. It really looks like between education and social media and this awareness and partnering with the healthcare system that you all are actively doing this. And so we won't dive into, I won't read this slide to you, but there are a lot of different ways that we can reassure patients that cancer screening is safe to do during the pandemic. And so these are following your kind of regulatory guidelines that are in place for preventing COVID. And so there's CDC has recommendations too on how to reduce the risk of COVID transmissions for healthcare facilities. And so just to highlight, and the main takeaway from cervical cancer screening during the pandemic is for those at highest risk for cervical cancer, access to cervical cancer screening should be prioritized. And so of the people who priority should be given to for screening, we want to look at those who are under surveillance for a previous abnormal screening result, those who were previously scheduled for follow-up exams, colposcopy. So this is what happens after you get a positive test. This is a visual inspection of the cervix to see what changes are going on, or excisional treatment. So looking at biopsy and also where can we remove the area that is burdened with disease. And then those who are overdue for screening. So these are your top priority areas when thinking about who should we really be working with to increase screening and get people back into screening as a result of having those appointments canceled or missed because of the pandemic. And then here are some strategies. I saw some of you all working on these between professional education, maybe reminders, reducing structural barriers, small media, so looking at that social media. A lot of you are in this space, but these are recommended evidence-based interventions for cervical cancer screening that you'll see here that are kind of geared towards maybe the public and the patients. Some are geared towards the providers and some are geared towards this access for care. So these are for screening and these are for HPV vaccination. And I highly recommend talking to your ACS staff partner. Tina, I know, is on this call and she's wonderful. And if these are ever questions for you about implementing evidence-based interventions, she's a great place to start and really talk through these conversations too. All right, my last Slido poll. I really appreciate your engagement here. If you have a key takeaway for today, I would love to hear from it. I really appreciate your time and attention today. And I just want to leave you on this note that cervical cancer is one of the most preventable cancers. So it's really encouraging to see you all here today so that we can continue to decrease the lives burden and loss to this cancer. And eventually we can eliminate this cancer, and we need all the boots on the ground. So I really appreciate you being here. And I'm excited to see what your key takeaways are from today. Keep up the good fight, new information about screening guideline. Age and frequency of screening, guidelines change. It's important to stay up to date on the latest recommendations. Yeah, we really appreciate your time being here. Great, we'll just wait for a couple more. If they want to throw them into the Slido poll, you can also throw them in the chat too. Data science and reasoning, new guideline information, the impact of the pandemic. Great, this is awesome. Thank you so much. And I will turn it over to questions. And I will go ahead and stop sharing my screen so that we can see each other and maybe have more of a discussion base. So I'm going to go ahead and stop sharing. And I can see you all. I hope you all can see the presentation being ended. And I see some comments in the chat here too. But if there's a way, Star, that you wanted to do questions and answers, I don't know if you received direct questions. I'm happy to take them. And Debbie is also here. We have an amazing resource with Dr. Debbie Saslow being here to help answer some questions that you all might have.
Thank you so much. I have not received any direct questions. So if there's anyone that does have a question, feel free to raise your hand on Zoom or put it in the chat box, and we'll kind of facilitate those so that we're not talking over each other. And then I did see the question about the slides, and those will be shared along with the recording on the YCC website. So it'll probably be in the next YCC newsletter. And then anyone who registered on Zoom for this meeting will also get just a direct email with those links. So hopefully that answers that question. You know, I'm really excited about the comment that you made on if we're doing the right things, if we're getting everybody screened, that cervical cancer can be a thing of the past in only a few short years. You know, 2060 is just right around the corner. There's quite a bit of work to do, but it's great to see that there could be a light at the end of the tunnel, and we just have to kind of chisel away a little bit at a time.
Yes, it's really exciting to hear that. It's definitely some inspiration that keeps me going. Okay, I see a question in the chat, and maybe this is maybe a good question for Debbie to jump in, or Tina, around, do we know where Wyoming is at with HPV vaccination rates? I don't have the state level data pulled up in front of me, and I saw Debbie, you come off mute, so I'll let you take it.
I don't either. Maybe someone in Wyoming knows. They do publish those. The latest data does not account for COVID. And yeah, I had a gut feeling that it was on the low side, but thanks, Star, for putting in 37%. That's far below the US average. And Star, is that complete, up to date?
So I just got like a mid-year report just like 2 weeks ago, and that was the current data at the time. So it's not the most recent published data, but the most recent published data I think was 34%. So we've made a little.
So up to date, 2 doses.
Yes.
Great.
I think our 1 dose rate is like 7% low.
Well, if you have any other questions too, I know our emails are in the slide, or you can, I think my email may be attached to the calendar invite. But if there's any questions too, I mean, Tina, you are our Wyoming ACS staff person, so I don't know if you wanted to come off mute and say anything, but welcome to take questions here. But I hope that this was informative for you all, and if there's other questions, just let me know.
Yeah.
Thanks, Jane. And those of you I haven't met, Tina Turpin, and feel free to reach out. I think we want this to be a starting ground for thought. So if you're thinking through, okay, I could do this, could I do this? We're great collaborators, Star, myself, and we have access to Jane and Debbie to really get things kind of moving for you guys. So if there is something you're dreaming up and don't know if someone else has tried it or if it's possible, please reach out and we can definitely connect you to resources.
I have a quick question if no one minds. So I found a couple peer-reviewed articles and whatnot where they focused a lot on how one of the challenges for rural communities is actually that our providers don't push it or have enough HPV vaccinations readily available. Do we have any suggestions or how to go about encouraging and changing some of the mindset, since vaccines in general are kind of a hot topic right now? Because I know just even talking with a few providers, they've just been like, no, I'm not even going to talk or even touch about this.
Yeah, I don't know, Jane, if you want, do you have anything, or Debbie? I'm happy to chime in as well.
I was just going to say, prior to coming onto this role in more of the cervical cancer screening space, I was involved in a project that worked across several rural Mountain West states. And your sentiment is not alone compared with other rural Mountain West states too. And I saw Debbie come off mute too, so if she wants to jump in here. But it is something that I remember having to do a lot of work on and outreach and networking on.
Yeah, this is a priority for CDC as well. They've been tracking the rural disparity across the United States specifically for HPV vaccination. I don't think we see it much for other vaccines. So these are kids going to get vaccinations, often from a family practitioner rather than a pediatrician. I've been, as someone who's always lived in highly populated suburban areas near major urban major cities in the US, I've often been surprised to see the data across rural counties of how few pediatricians there are, often 0 to 1 per county. And so I think pediatricians are pushing vaccines a little bit more maybe than family practitioners. We've also seen, as far as one opportunity that, and I'm not sure what the pharmacy regulations are in Wyoming, but I know in some states such as Utah, they've looked more at trying to get more pharmacists and pharmacy located HPV vaccination, just because there's greater access, but there are a lot of issues with that. So the pharmacists and pharmacies need to be signed up with the Vaccine for Children's program so that there's not a big cost. So that's one possibility. Tina?
Yeah, I was just going to add too, just some strategies we've been trying. And if you're seeing this in certain clinics, please reach out, because I think education is number one. If someone is reluctant, a provider is reluctant to recommend the vaccine, usually it's because they're not confident in their recommendation. So how do we strengthen that where they feel confident getting any pushback, getting any questions? They know the science has led us here. They're confident in it. And so education's always number one for both Star and I know she'll agree. And secondly, we have had great luck in rural areas with provider champions. So if you have someone in the area who is a physician who is great at recommending the vaccine and is in huge support of it, it's always nice for me to have them with me when talking to their peer. So it's really nice, that kind of peer-to-peer conversation that they're able to have, that me as a physician, I'm not able to have that. And so that has been a really great strategy in the rural areas as well. But yeah, I mean, the mindset is a little different in those parts, and it just, we're chipping away at the rock little by little, but it's just kind of having those continued conversations and education.
Great, and I see Haley put in the chat some strategies that they've been using around discussing the vaccine as cancer prevention. Let's see, using presumptive recommendations and a sandwich method as strategies to help increase HPV vaccination and recommendations from the providers. So great. I don't see any other questions unless anyone else has any that they'd like to come off mute. Okay, Star, I'll turn it back to you.
Awesome. Thank you so much again for that amazing presentation and all the information that you've provided us today. There's definitely a lot of great takeaways, and I hope that you were able to find something that you can implement either in your WCRS contract work or in your coalition work or in a clinic setting. I know that there's a few public health nursing offices on the call today as well. So definitely feel free to reach out if you have any other questions. I will send all the information to everyone, and we appreciate you just being on the call and continually supporting the coalition work and the Wyoming Cancer Program. So thank you everybody for joining today, and have a wonderful rest of your, is it Wednesday? Is it Thursday? The holiday always throws me for a loop.